Okay, so with cranial cruciate disease, along with hip dysplasia, that's probably the second most common orthopedic abnormality you're going to have to deal with on radiographs when you're out in practice. So, extremely common cranial cruciate disease. Realized that in people, it's also extremely common. In fact, I've had it surgically repaired, but in people, it's called anterior cruciate disease, and you'll hear people refer to it as ACL tear in humans. You'll also hear veterinarians say the dog has an ACL tear, which really is not correct because animals and dogs and cats don't have anterior and posterior cruciate ligaments as people do. They have cranial and caudal cruciate ligaments. And so ACL in an animal is really not correct to use, even though people do it all the time, just the same way that people say the dog, I got to check out my dog's knees. Well, dogs don't have knees, they have stifle joints. So anyway, so cranial cruciate disease, what do we see with that? We've already kind of alluded to it a little bit before. Cranial cruciate disease can happen in any dog, and more commonly in any dog that's probably over at least a year age. It's really, really pretty rare to have dogs that have cranial cruciate tears less than a year of age. If I see a fusion or swelling inside the stifle joint of a dog less than a year of age, typically I think osteochondrosis more is going to be more common than a dog that would have cranial cruciate disease that's less than a year of age. Some people say females more than males. I don't believe that. I think it's pretty even. And a lot of these dogs will, the typical scenario, they're middle-aged dogs, they're happy, healthy, running around. The dog goes out in the backyard and sees a squirrel or a cat and immediately chases after it full force. And that full force, acutely, they will tear one or both of their cranial cruciate ligaments. You'll hear them go yelp in pain, and they come in and they won't use one leg. Is a typical scenario that you're going to see. So again, just to review the anatomy just a little bit, here's a lateral view. The cruciate ligaments in a dog are named for where they attach to the tibia, so the distal attachment. Okay, so the cranial cruciate ligament attaches to the cranial aspect of the tibia. The caudal cruciate ligament attaches to the caudal aspect of the tibia. They kind of make an X as they cross. Okay, both of these ligaments are within the joint capsule. So the joint capsule itself is going to be right up in here and right back in here. And inside that joint capsule is also the synovial membrane and synovial fluid. Okay, so because that's inside of the joint capsule, if this ligament right here, the cranial cruciate ligament, tears right in here, immediately you're going to get blood and hemorrhage that start to form inside that joint capsule, which causes a fusion to form in the joint capsule, and that joint capsule starts to extend cranially, like we talked about, and compress or push on the infrapatellar fat pad. Okay, so again, this is usually young, fit, active dogs. Suddenly they take off chasing something, and then they come in and they're extremely painful. So this is a lateral view of a normal dog, normal stifle joint. Again, just to review, this is the distal end of the tibia. That's the proximal end of the, or distal end of the femur. This is the proximal end of the tibia. Patella right in here. These are two sesamoid bones. They're called the sesamoids of the gastrocnemius. People will also refer to them as the fibella. And then there's another little sesamoid bone that sits right back in here called the popliteal sesamoid bone that sits right back in here. Okay, but the thing from this slide that you need to gather is this is the size of the joint space cranially. So inside, that's the edge of the joint space. This is the nice, well-defined infrapatellar fat pad. Great big, different opacity than soft tissue because it's more dark, right? And so we have the synovial membrane right in here and a little bit of joint fluid in here. So very small joint capsule here. And again, the caudal extent of it is this line going right through here, is the caudal extent of the fat of the joint pouch. So inside here, inside that joint, that confined to that area, is the cranial and the caudal cruciate ligaments and synovial fluid inside the joint. Okay, so that we know the cranial cruciate ligament is going to extend from here down to somewhere about here and attach. So in that direction, the caudal cruciate ligament is going to go from about here and attach down to back here in that direction. Okay, so they're named to where they attach on the tibia. Okay. So if we have, again, there's just our example that we just saw here. The other thing to note is that if you've worked for a vet, you may have done this in your time there at St. Matthews, but we also describe this thing called a radiographic drawer sign. Okay, and then when you feel the dog's stifle joint, we assess these dogs that may have cranial cruciate disease if they have a drawer sign that you can physically feel on your orthopedic exam. And basically, if the two cruciate ligaments, the cranial one and the caudal one, are intact, this joint should be pretty stable. So if you try to grab the top end of the femur and the tibia and you try to move the joint cranially or caudally, that you shouldn't get hardly any movement in there. If one of those ligaments is torn, then you'll get a drawer sign. It moves really freely. This part of the tibia will move back and forth this way. Okay, that's called a drawer sign. Well, sometimes radiographically, you also get the appearance of a drawer sign even on the radiographs. Okay, and a radiographic drawer sign, kind of one of the keys that you can do that it holds true probably 80% of the time, is this is the back end of the fibula right in here. And if you put a straight edge, like a piece of paper or a ruler, on the back end of the fibula and you extend that line proximally, it should hit right at the back end of the femoral condyles, right in that area. Dogs that have, like this dog here with the radiographic drawer sign, then that part of the fibula will extend more cranially because this whole part of the tibia and fibula is now allowed to move cranially because the cruciate is ruptured, the cranial cruciate. Then that back into the fibula will intersect where the femoral condyles are. So here's an example of that. This is a normal dog. If I take this red line, if I take this red line and I extend it from the back end of the fibula up, it should intersect right back here where the femoral condyles are. Okay. This dog has a radiographic drawer sign. So look at the displacement. This back end of the fibula now, instead of intersecting back here, intersects right in the middle of the femoral condyles. Okay. This normal dog here doesn't have any effusion. Nice, well-defined joint capsule here. Nice, well-defined joint capsule here. This dog's got some fluffiness inside the joint itself. I don't see the nice, well-defined joint capsule, so he's also got some effusion in the joint space. So what do we see if a dog has rupture of the cranial cruciate ligament? Immediately that ligament's going to tear. We're going to see hemorrhage. We start to see effusion start to form inside the joint. Within weeks, if that joint's unstable, then again, you're going to get osteophytes that form, periarticular osteophytes that start to form around the stifle joint. Early on, you'll get swelling. You may get a radiographic drawer sign, and then later on, you'll start to get osteophytes. So these are osteophytes here on the distal aspect of the proximal patella. You'll get them down in here in the region of the tibia. You'll get them up here with the fibella or the sesamoids of the gastrocnemius, and very commonly up here on this part of the trochlear ridges of the femur. Sometimes you get a little joint mouse. Okay. Also, if you dogs and cats can both tear their cranial cruciate ligament or their caudal one, except 99% of the time it's going to be the cranial one. Okay, caudal cruciate disease in dogs happens, but it's really rare. Okay, so again, here is a dog that has cranial cruciate disease. Here's a dog that's normal. Okay, so normal here, again, nice, well-defined little big old fat pad, little joint space right up in here. This dog now has a lot of effusion. You can see now, instead of the joint space confined to just this little triangle here, now it's all of this. And that's because he's starting to have a lot of effusion and hemorrhage and increased synovial content inside that joint. Okay, caudally, you can see there's the edge of a normal dog of the joint space, very small little triangle that's full of synovial fluid. Now we got this bulging area in here. So we've got all this effusion and hemorrhage and synovial accumulation inside that joint space. Okay, we've also got a bunch of little mineralized opacities in the joint. There's a little divot right in here. Well, these are avulsion fractures from where that cranial cruciate ligament has pulled off of and ripped off part of the bone where it attached to the tibia. Okay, the ligament itself we're not going to see. In a normal dog and a dog that ruptures their ligament, that ligament is made out of soft tissue opacity, just like the joint fluid. So it's going to silhouette together and you won't see it. Okay, so the key to look for is effusion inside the joint, obvious effusion inside this joint. these, sometimes you'll see these mineralized fracture fragments or avulsion fracture fragments, but then look at the osteoarthritis. He's got roughening up in here. So he's got osteophytes forming up in here in the trochlear ridge of the distal femur. Here you really don't see it. Over here on the distal aspect of the patella, we've got a big old osteophyte that's forming on the distal aspect of the patella down in here. Okay. And look, he's got some roughening of his fibula up in here too. So a little bit of degenerative changes that are occurring there too. And also, this dog's got a radiographic drawer sign. If you took the back straight edge with the back end of the fibula and you extended it proximally, it's going to come right up and about right, intersect it right about right there. Okay. This dog is normal. Back into the fibula, it's going to come right back up in this way and intersect back here right at the edge of the condyles. Okay. So the other thing to look for on the cranial caudal view sometimes, and you will palpate this when you actually feel these dogs' stifle joints, is how he'll have swelling or effusion on the medial aspect of that stifle joint too. And people will describe that when they feel it on the orthopedic or physical exam as having a medial buttress in that area. Okay, so that's just swelling inside the joint in that aspect of the joint. Okay, so osteoarthritis, there arrows where I just pointed out. So there's another dog with same thing. He's got little mineralized opacities here, but he's got osteophytes here on the proximal patella, on the distal patella, starting to form up here on the trochlear ridges of the femur. And these can get really obvious and really bad. So here's more osteophytes here. So this is just a dog with chronic cranial cruciate disease. And of course, right now there's several ways that people can fix these. The surgeons can fix them. The most common one is going to be a procedure called a TPLO, which we don't need to get into, but you will when you talk about surgery. And there's several other ways to fix these dogs with cranial cruciate disease. Unfortunately, again, once they get degenerative changes like this, no matter even if they fix them, the degenerative changes will usually progress over time. Although the dogs, once they have surgery, they seem to be less lame and less painful. So that's probably a good thing. The other thing to keep in mind is when you are shooting lateral views of the stifle joints, the lateral views, just like everything else, have to be properly positioned, really well exposed, nice radiographs. Okay. And by that, I mean the left and right sides of the femoral condyles have to be perfectly straight and superimposed over each other. If they're splayed apart like this, there's no way to evaluate for effusion in the joint space because now the femoral condyles get in the way and you can't see the joint space. Here you can see it very well. Here you can't because he's crooked. Okay, so radiographs centered over the stifle joint, they have to be nice and straightly positioned to be able to diagnose this disease. Look at this dog's radiographic drawer sign. Here's the back end of the fibula. You come up here and it intersects the condyles way up here. It should be way back here. So this whole part of the tibia is cranially displaced. And why is that? That's because his cranial cruciate ligament that normally would hold it in place is torn. And so this part of the tibia is now allowed to go cranially. That's called a cranial tibial thrust. Okay, cruciate disease, super common. You need to know how to diagnose that based on radiographs. And again, it's going to require a well-positioned lateral view centered over that stifle joint to diagnose it. Luxating patellas. Let's talk about luxating patellas a little bit. This one is also really common, and this is usually smaller dogs. Sometimes it's a large breed dog, but most of the time it's going to be smaller dogs that will have luxating patellas. Obviously what a luxating patella is, the patella is not in the normal anatomic location. The majority of dogs that have luxating patellas, they'll have medially luxating patellas. Some of them will have laterally luxating patellas, but nowhere near as common. This is an easy diagnosis to make. These dogs come in, they're painful. Sometimes they're intermittently painful. Sometimes they will go three-legged lame. And then their patella pops back into where it's supposed to be because these can be dynamic. They can move in and out of where they're supposed to be. And so when the patella pops in where it's supposed to be, the dogs can run around. Usually they're non-painful and they have normal use of the limb. But then the patella will luxate again back where it's not supposed to be. And that's when the dog is lame. So it's kind of sometimes an intermittent lameness. So it's not hard to diagnose luxating patellas. You have to have a nice straight view centered over the stifle joint, and you look for where the patella should be. Normally, it should be right here in the middle of the shaft of the femur. This patella here is medially displaced. Sometimes they can go way off laterally, but more often than not, they're going to be medially luxating patellas. Okay. The other thing is, remember, the patellar ligament hooks on there and goes right from the patella to the tibial plateau. And so a lot of dogs that will have medially luxating patellas over time, that will cause the distal end of the femur to kind of bow laterally, and it will cause the proximal end of the tibia to kind of bow medially. Okay. And you're going to see that very commonly when they have luxating patellas. But again, you have to look for, where is the patella located? Here it's located medial. Same cartoon here, medial to where it should be. It should be sitting right in here. Also keep in mind that a lot of dogs that have patellar luxations, they are dynamically luxating. So just because on one radiograph you see the patellar sitting here, that doesn't mean that it couldn't be dynamically luxating. So you still have to do your physical exam, orthopedic exam, grab that patella with your fingers and try to make it luxate. It shouldn't luxate in a normal dog. Okay? So here, again, not a hard diagnosis to make. Here's a cranial caudal view of this dog's stifle joint. The patella should be sitting right here. And no, now it's way over here. Okay. So, and this is obviously the medial aspect because there's the fibula, which is always going to be lateral. So medially luxating patellas. The lateral view, you don't see it. Normally the patella should be sitting right in here, but now it's next to the femur. And so it's very vaguely seen superimposed over the femur. So it's not in the right spot. Okay, here's a dog with bilateral hip dysplasia, but also bilateral medially luxating patellas. So here's one patella here. Here's the other patella here. They should be sitting right in the mid shaft of the femurs, and they're not. Okay, because of the patellas there, you can also, the medially luxating patellas, if you look at the distal aspect of this part of the femur, it's kind of laterally bowed. You can really see a medial bowing of the proximal aspect of the tibias on both sides. Okay. And because this joint is unstable now, because of the patellar luxations, we start to get arthritis. So we get osteophytes here, we get osteophytes on the trochlear ridges that you can see here on both sides. Okay. So same thing, an unstable joint, but now it's due to luxating patellas. He's got like I said, he's got hip dysplasia too. So his dorsal acetabular rim on this side, you can see it covers maybe a third of the femoral head. This side maybe a little more than a third, but sure not adequate coverage on either side. So he's got hip dysplasia, plus he's got medially luxating patellas with moderate chronic DJD of both of those stifle joints. Okay, what do the surgeons do? They can go in, and most commonly they'll do this procedure called a tibial crest transposition, which you'll learn about in surgery, which tries to help stabilize that patella, put it back where it's normally supposed to be in that patellar groove. And then they can deepen surgically, they kind of scoop it out and deepen the patellar groove too, make a little line in here to hold that patellar where it's supposed to be. Okay, arthritides, we already talked about chronic DJD. We talked a little bit about septic arthritis. When we talk about arthritis and arthritides, different types of arthritis in dogs, we can it's kind of like nasal passages. We can say, is it destructive arthritis or is it a non-destructive arthritis? The difference is, do we see evidence of bony destruction or just a fusion in the joint? Okay, so we kind of subdivide it into those kind of things. The destructive arthritis, the erosive arthritis is the ones that's going to be more serious and cause a lot more pain. The most common one that you're going to see as a part of a destructive or erosive arthritis is going to be rheumatoid arthritis. And this happens in almost exclusively in small breed dogs. So little teacup poodles and little Yorkies and things like that. Usually it happens when they're middle-aged to older, and they get little pinpoint areas of destruction and it always starts in the carpus or the tarsus. And they get little areas of bony destruction of the carpal bones or the tarsal bones and a lot of effusion surrounding the joint. And this is an autoimmune disease, so it's not infected. It's not due to bacterial infection in the joint space. It's due to the body making antibodies that attack its own self. inside the joint spaces itself. The treatment for these is usually steroids. So again, when you see these, again, you'll look for, here's a kind of a cartoon of a dorsal view of a carpus. And here's the radiocarpal bone, there's the ulnar carpal bone, and you can see you look for these little areas of discrete bony lysis associated with the articular surfaces around the carpus. And as this disease worsens, these areas become bigger and bigger, and eventually this bone will fracture. Okay, and then you get pathologic fractures due to this erosive arthritis. The joint spaces become really narrowed, and you get a lot of swelling inside the joint space itself. So here's a dog with osteoarthritis. That's an erosive arthritis, rheumatoid-like arthritis. And you can see the joint space is narrow, but look at these little lytic areas inside the joint in the carpal bone here, the radiocarpal bone here. There's another one here, little focal areas of lucency here inside the joint space, and a lot of swelling around the joint space. And these can get so severe that it completely erodes the carpal bones where they're basically not even existent anymore. So really narrow disc spaces, lots of erosion and destruction of the carpal bones. This one, it could, you could say, well, maybe he's got a septic arthritis, and you would diagnose that or disprove that by getting a copy or a sample of the joint fluid out of there, out of the middle of the carpus, and looking at that joint fluid under the microscope and make sure it's not infected or have degenerative neutrophils or anything inside of it. This erosive polyarthritis, that rheumatoid, again, it's going to be restricted for the most part only to small breed little dogs, and it always affects more than one leg. So it usually is going to affect both of the carpi, both of the tarsi. And if it gets really bad, it can move and also affect the stifle joints and the elbow joints and things like that. But it's almost usually starting off and most of the time restricted to the carpus and in the region of the tarsus. And again, steroids is going to be the way to treat these, and it palliates it. It really doesn't do anything to cure that. Okay, so this is a dog with, again, chronic rheumatoid, got some loosened areas right in here and here. You can see the bony destruction of the carpal bones and lots of effusion around there. And of course, it's also going to destroy all the ligaments that are inside the ligaments inside the carpus, and the medial and the lateral collateral ligaments. It will destroy those too. And then the joint's unstable, and that adds to the, because again, it's an unstable joint. Body says, what do I do with an unstable joint? Let's start putting osteophytes around it, and that adds to the radiographic appearance of it and also the discomfort for the animal. So here's a normal side here. Here's an abnormal side with lots of effusion. Look at all this swelling around the joint, all these little osteophytes and joint mice. Okay, osteomyelitis is the same thing as a septic joint that we talked about before. Except osteomyelitis is not, by definition, not an infection in the joint. It's an infection of the bone itself. Okay, it's pretty rare to see these. When you do, most of the time the osteomyelitis is going to be in younger dogs, except sometimes you'll see it also in dogs that have had gunshot wounds or trauma that with a penetrating wound into the bone. So what do we see with osteomyelitis? It's a bacterial infection of a long bone. And it sets up shop in the periosteum. And then, so then you start to see bony destruction and periosteal reactions like we talked about to begin with in this lecture series. You also see the cardinal signs of inflammation. So that area around the bone is going to be painful. It's going to be red. If you clip the hair and look at it, it's a lot of swelling. So all the cardinal signs of inflammation. Sometimes you'll have draining tracts if you have bacteria and pus that's being produced inside the area. Sometimes in other dogs, you'll see it, especially in puppies, as concurrent of systemic disease. So again, sometimes they can get pneumonia, they can get an infection of the umbilicus when they're puppies, and then it can set up shop inside a joint or associated with the bone itself and cause an infection. So lots of things, any kind of bacteria can also cause osteomyelitis. The most common is going to be staph or strep, just because they're the most common bacteria. So what do we see with osteomyelitis? Again, this is a periosteal reaction. You can see it's kind of spiculated in here. The underlying cortical bone may be a little bit thinned. We got this lamellated periosteal reaction extending way up here around that part of the bone, and lots of swelling, lots of soft tissue swelling kind of centered around this joint space itself. So this is probably a septic joint, good chance of it. And he's got this area in the bone itself that is infected. It looks semi-aggressive with it based on this type of periosteal reaction with all this swelling around it. Okay, so I would rule out this could be some type of early tumor. It could be a bacterial or fungal osteomyelitis or infection of the bone itself. And again, these dogs are going to be really, really painful. A lot of times they'll have fever. And the only way you're going to know for sure to diagnose this is you get a needle or biopsy this area of the bone and culture it, do bacteria cultures and fungal cultures to see if you can diagnose the specific etiology of what's causing that condition. Okay, so lots of periosteal reactions. Okay, this is another dog here that in a digit. So here's normal digits, lots of swelling. Look at all the swelling around this digit. And here's the first phalanx, second phalanx. Well, the third phalanx, this part here is gone. So it's completely lytic, completely gone. But I've got all these irregularly shaped osteophytes and this periosteal reaction around that part of the first phalanx with severe soft tissue swelling. So this one here is a really good chance if this dog is, if he's young, if he's 1 or 2 or 3 years of age, this could be a really bad infection with cellulitis due to previous trauma. Maybe he ripped off this third phalanx and now it's infected. If this dog is 10 years of age, I'd start thinking more in the lines of it could be neoplastic. Okay, but again, you can see all this periosteal reaction even up down into the metacarpal or metatarsal areas in this dog here. Okay, again, biopsy or swelling is how you're going to be able to diagnose that. Bacterial osteomyelitis, same thing that we just talked about. A lot of soft tissue swelling, maybe some periosteal really swollen, fever. Put the dog on appropriate antibiotics, and over time they'll probably get better. Here's an example of a femur. This dog had osteomyelitis. So I can see there's this kind of faint periosteal reaction here, associated with this femur. Not really any bony lysis, so that's a good thing, but probably very mild osteomyelitis around that part of the femur. And again, you look for other signs. Does he have a high white cell count? He's got a fracture of the femur, you can see here, which probably is an open fracture and led to this infected bone. That an infection of the bone is called osteomyelitis. Okay, another dog. This dog had surgery, so we have 2 screws up in here, but now we've got all this periosteal reaction around that part of the femur. So most likely it's infected due to previous trauma and or surgery that they didn't have sterile procedure. Okay, last but not least, I think we're going to talk about bony neoplasia. The most common primary bone tumor of a dog you've probably seen in your past experiences, an osteosarcoma, is really pretty damn common in large breed dogs. Has no breed predilection. It tends to set up shop and be localized in certain parts of a bone, which we'll talk about. Most of the primary bone tumors in dogs that get these are going to be middle-aged to older dogs, which is what you would expect. It's an aggressive cancer, extremely painful in these dogs. They can readily metastasize to lung, it's a really common issue that you're going to see going forward. So what do you look for? Is you look for the site of the lesion, you look for evidence of pain, you look for, hang on just a second, pain, you look for a solitary destructive bony lesion. These are easy to spot radiographically. Not much else really looks like it. So we look for, this is a proximal end of the humerus, something that's causing a severe, highly aggressive periosteal reaction, maybe some soft tissue swelling and a lot of bony lysis of that bone. If it left unchecked over time, a lot of times that bone becomes so weak, then it will fracture, which we know now is called a pathologic fracture. So here is an aggressive bone tumor. We look at the periosteal reaction here. It's spiculated, amorphous, aggressive-like periosteal reaction. We have a lot of thinning of the cortical bone, especially back here. It's really, really thin. This Codman's triangle, remember we talked about that as these cancer cells and pus extend up the periosteum. It lifts the periosteum up. We said a Codman's triangle is typically seen in aggressive bony tumors. Now, most of the primary bone tumors, probably 95% of primary bone tumors, they love to live in the metaphyseal regions of bone. So in the distal end of the long bones that flare out is where they tend to set up shop. Much less commonly will they be in the diaphyseal portion of the bone. And look at this one here, you can see it's in the distal aspect of the radius, probably started down here in the metaphyseal region. Now it's spreading proximally as it gets bigger and bigger. So thing to recognize, bony lysis, lots of soft tissue swelling and a very aggressive looking periosteal reaction around that part of the radius. The other thing that's kind of weird about primary bone tumors is osteosarcomas, I should say, is they do not typically cross joint spaces. And so they may extend proximally up the bone and up the periosteum, but for whatever reason, they don't like to cross synovial joints. Okay, so they rarely will cross to the other side of the joint space. So this looks perfectly normal down here. It extends proximally, but there's a joint space here and it doesn't like to cross joint spaces. Okay, so ill-defined, nasty periosteal reaction, aggressive, lots of bony destruction of the radius and the ulna. Here's another one, kind of very aggressive amorphous periosteal reaction surrounding this distal end of the radius. Okay, and if you see that in these dogs, they're going to be middle-aged to older. They're come in three-legged lane. They're extremely painful. They're not using the leg at all. It's swollen. You radiographic. You see something like that. If it's an older dog, you're probably 90% of the time you're going to be right. It's going to be a primary bone tumor, an osteosarcoma. If he's a 2-year-old dog, then I would consider fungal osteomyelitis. So he could have a nasty fungus that's causing an infection of the bone. It can look just like this if it's a younger dog. And also it kind of depends on where the dog comes from. If you are from Arizona or Nevada, out in the desert areas like that, there's coccidiomycosis is super common out there. And it's not unusual to see young dogs like this that come in with coccidiomycosis, and it looks for everything like it's going to be a tumor. Again, the key is in these dogs, most of the dogs, if they're middle-aged to older, it's going to be cancer, osteomyelitis, or it's going to be cancer due to an osteosarcoma. If it's a younger dog that lives in an area that is known for fungal disease, like in a desert area, you would have to put fungal osteomyelitis on that list as well. Again, another primary bone tumor, lots of lysis, kind of an expansile look lesion in the distal end of the radius in here, and an ugly periosteal reaction. Here's another osteosarcoma in the proximal end of the humerus, lots of bony lysis, lots of thinning of the cortical bone in that area. And again, you look for where does the tumor end and begin. Down here in this part of the diaphyseal portion of the bone, it looks very normal of that humerus, but it's kind of extending distally from the metaphyseal region, extends down the bone. Again, it will hardly ever cross a joint space. But now with that aggressive bony disease is extending down the bone, and where it extends down the bone, where what we would call the zone of transition, where it goes from diseased-looking bone to normal-looking bone, is poorly defined. It's hard to find exactly where that stop and begins. Okay, lots of bony lysis destruction here. And that bone, as you can imagine, is becoming weaker and weaker and weaker. And eventually, just by walking around, it's going to fracture through that bone and you're going to have a pathologic fracture. So primary bone neoplasia, the one we talked about just then, is an osteosarcoma, is going to be the more common ones. And kind of a saying or that it usually holds true is osteosarcomas love to live toward the knee. So that means in the distal end of the femur or the proximal end of the tibia and away from the elbow. So that means they live in the shoulder or the distal end of the radius or ulna, not in the elbow area, but towards the knee. So towards the knee and away from the elbow is something to kind of keep in mind with primary bone tumors. And almost always primary bone tumors are metaphyseal in location. They can spread away from that area, but they start in the metaphyseal. The other type of bone neoplasia that's more rare, but you will see, is not primary bone tumors like an osteosarcoma. This is metastatic bone tumors. So these are going to be neoplastic cells that start off in another cancer somewhere else, like a mammary gland carcinoma or a transitional cell carcinoma in the urinary bladder, then can metastasize to the bone. And when you see metastatic bone disease, most of the time it's going to be in the diaphyseal portion of the bone instead of the metaphyseal portion of the bone. So if I was to ask you on a quiz, most primary bone tumors, do they usually live in the diaphyseal portion of the bone or usually live in the metaphyseal portion of the bone? Most primary bone tumors always live in the metaphyseal region. The opposite is true for metastatic bone tumors. Okay, we already talked a little bit about multiple myeloma when we talked about neurologic disease, but again, multiple myeloma, you see these pure lytic lesions in multiple bones. A lot of times you'll see it here in the dorsal spinous processes, but here you can see in the even in the humerus, there's these lytic lesions in that part of the humerus that you can see, these lytic areas all in the humerus. Look at this in the distal femurs. It looks like somebody got a hole puncher and just started punching out parts of the bone in here. And again, multiple myeloma is one of those really, really aggressive tumors. You'll learn more about them when you take oncology, but you have to have three things that you diagnose to make a definitive diagnosis of multiple myeloma. And one of them is these lytic lesions at multiple sites throughout the skeleton. Okay, benign bone cysts. Every now and then you'll have an animal that'll have a lytic lesion anywhere in the bone. Most of the time they're metaphyseal region. But the difference is in these, they're expansile in their appearance, but they're relatively well defined. Sometimes they're almost surrounded by sclerotic bone or bone that's really opaque around that area. And these dogs will come in and the owner may have noticed that area looks swollen, but usually these dogs aren't painful at all. Okay. And they can be young or middle-aged, but sometimes you'll just get a cyst that forms in the bone. It can cause the bone to become weak, and sometimes it becomes so weak it fractures, but this is not an aggressive tumor. But unfortunately, the only way to know for sure, is this a benign bone cyst or is this an aggressive, primary bone tumor like an osteosarcoma? You're probably going to have to go in and biopsy that area to know for sure. But again, one of the key differences, if obviously you would be hopeful that it's a benign bone cyst because these usually go away on their own. But if it's a benign bone cyst, these dogs, most of the time, they're not painful. Dogs that have primary bone tumors, osteosarcs, are extremely painful. But you have to biopsy them to know for sure. So here's another, this is a weird one. This is a osteoproductive lesion that lives inside the marrow cavity. So this is a tumor that lives inside the marrow cavity called an enchondroma. You'll probably maybe see those once in your career. This is why you send them off to radiologists. There's another one that causes bony production, usually associated with a tooth or a tooth root. This is called an odontoma. So some of the weird ones that you see. But again, these can be primary bone tumors. There's different types besides an osteosarcoma. There's chondrosarcomas and things like that. But you have to recognize that, again, sometimes they're going to be more aggressive. Osteosarcomas are extremely aggressive, as opposed to some of the other ones that aren't quite as aggressive. We briefly talked about metastatic bone disease. Again, these are ones that can come from prostatic carcinomas, transitional cells that now metastasize to the bone. So this is a nuclear medicine procedure that I did years ago in practice. And this is a way to assess for primary or metastatic bone disease. This dog had a osteosarcoma in the that's this big black hot spot in the distal end of the tibia. We knew he had a primary bone tumor, so we want to take chest phones. We want to make sure that has not metastasized to the lung, because the owners were considering, do they want to just amputate this leg? But it would be really nice to know before you would spend the money and put the dog through that procedure. We want to make sure as best we can that the dog does not have metastatic disease to the lung or anywhere else in the skeleton. So we radiographed the lung, didn't see anything in the lung. We did this procedure called a bone scan. And again, it's that woman I showed you the example early on about that had a bone scan. It's kind of looking for the same thing in this dog. Has it spread anywhere else in the skeleton? We got all these other views of the skeleton, the other limbs, the ribs and everything where we know these tend to metastasize. I don't see anything that worries me. Everything looks good. Everything looks normal on this bone scan. So this dog would probably be a pretty good candidate to have that leg removed, because we can't find any chance or any area elsewhere that it might have spread to. On the other hand, this dog here also had a primary bone tumor. But now we've got multiple hot spots at different locations in the spine, on different ribs, some up here in the skull, some up here in the cervical region. There's a big hot spot right in here in a vertebral body, another one here. So this dog here has multiple hot spots all over the place. And so this dog has metastatic bone disease. And so this would probably not be a good candidate to take just one limb off, because we already know it's already spread everywhere else. Okay, another weird one that we have to talk about. We said that most primary bone tumors do not cross synovial joints. Well, there's one kind of tumor that actually starts in the joint and spreads both ways from the joint. So it can spread distally or proximally from the synovial joint. And these are called synovial cell sarcomas. So this is an aggressive tumor that starts in the synovial membrane and the synovial cells themselves, and then can set up shop in the joint and then spread to either side of the joint and affect the bone. So synovial cell sarcomas, you're going to look for aggressive bony lysis in the metaphyseal and epiphyseal portions of the bone, but it crosses and involves multiple bones. So we can see all these little lytic lesions in the distal femur. There's lytic lesions in the fibula, in the proximal end, and the distal aspect of the patella, and similar large lytic lesions in the proximal aspect of the tibia, with a lot of swelling and effusion in the joint space. So I'm looking at that. There's really only one kind of aggressive tumor that actually affects both sides of the joint space and causes effusion, and that would be one of these synovial cell sarcomas. Again, these are super aggressive. They can metastasize elsewhere to lung, to other parts of the skeleton, cause lots of effusion. The only way to diagnose this definitively is you have to go in and look at the synovial fluid, and you biopsy the joint capsule itself. And that would be how you would make a definitive diagnosis of a synovial cell. So if you have this dog into your practice and you see this and you think, I remember that from our radiology class, I think it's a synovial sarcoma. You're going to go back to the owner and you're going to say, it's not good. I think it's going to be an aggressive tumor, one of these synovial cell sarcomas. What's the next step that you probably are going to advise the owner, or that you should advise the owner that you need to do? What's the next thing to do? And in my mind, the next thing to do is chest films. You want to get chest radiographs. You want to look at the lungs and make sure this has not already metastasized to the lung. And because if you take x-rays of the lung and you see evidence of metastatic lung disease, is there really a need to go in and biopsy this? Do you need to put the dog through that, or the expense of it for the owner? And the answer is no, probably not, because if it's already metastasized to the lung or any other place, the prognosis is really bad. Okay. And so probably the next step would be get chest films on this dog and make sure it's not already metastasized to the lung. If it hasn't, the lungs look clean, then the next step would be biopsy the joint capsule and look at the synovial fluid to confirm this is a cancer. Here's another dog with another synovial cell. So it's all inside the joint, spreading on multiple bones inside the joint with severe soft tissue swelling around that joint. If this was a younger dog, if this dog was 2 and he's a hunter and, going out running around the field all the time, I would consider septic arthritis. But if this dog is 10 years old and he's not a hunter and things like that, then I would consider a synovial cell sarcoma. And again, the only way to know for sure is let's look at the joint fluid, let's biopsy the joint capsule. Okay, so again, what do you do next? You want to get chest films. So this dog has multiple nodules all over the lung. And if that's the case, then he's already got metastatic lung disease, very poor prognosis for no matter what you do. And so it probably wouldn't be a good idea then. You probably don't need to put the dog through a biopsy of whatever joint was affected, because you're not going to change his course at this point. No, you don't need a biopsy. Okay, so I think that's it for orthopedics. That worked out pretty well. We're finished the lecture on time today, and that gets us to a good break. And tomorrow we will start off with abdominal radiology, which I think you already have the lecture. If not, Adriana, please email me back to let me know. And if not, I will see you guys in the morning at same time, and we'll start with abdomen. Is that cool? All right. Have a good rest of your day. I'll see y'all tomorrow. Bye.
Hi.
Yes, Dr. Yes.